At this time, I'd like to introduce you to our speakers, Carla Brock-Wilbur and Louise Bride. Carla Brock-Wilbur, an accomplished nurse administrator with a background in critical care, education, and emergency services, joined Stridewater in 2014. Before Stridewater, Carla was Director of Enterprise Excellence. In this capacity, she led, facilitated, and supported the Lean Transformation Initiative across the continuum of care and health systems, and was responsible for the development, implementation, and ongoing assessment of the comprehensive performance improvement and lean redesign initiatives within the healthcare facility. Carla is also a seasoned clinician that works directly with patients in the facility's outpatient surgical department as both unit coordinator and as an endoscopy registered nurse. Louise Bride joined Stridewater in 2013 and has more than 30 years of experience in healthcare management and clinical operations. She has a proven record of accomplishments in developing and executing initiatives to enhance access and improve quality and cost effectiveness of healthcare delivery in both the public and private sectors. At Stridewater, she focuses on population health, strategic planning and operational improvement, and models of care including patient-centered medical home initiatives. Before joining Stridewater, Bride formed a healthcare consulting firm specializing in care integration, models of care delivery, provider relations, network development, and star rating evaluation and improvement initiatives. Previously, Bride served as Senior Clinical Director for United Health Group Ovations, Atlanta, Georgia, where she held the National Clinical Lead role for Ovations Medicare Community Program. She is a member of the American College of Healthcare Executives and is an NCQA Patient-Centered Medical Home Certified Content Expert. Now I will turn it over to Carla and Louise.
Thank you, Kim. I want to make sure that you can hear me well. I have had almost laryngitis, so as long as you hear me.
I can hear you loud and clear.
Great, great. So I wanted to tell you a little bit about Stridewater. We were founded in 1985, and our home office is in Portland, Maine. We have a corporate office in Atlanta, in Tennessee, and we have individual consultant offices across the country. We have a specific rural practice, and we work with a great deal of critical access hospitals, small rural community hospitals, and networks of hospitals as well. We also work with affiliations and partnerships, strategic planning and operational improvement, population health and employee health strategies, strategy master facility planning, physician and hospital alignment, and capital planning and access, as well as a division that is specialized in revenue cycle. So today we're going to talk about post-acute care and bundled payments and why is this important to you. This is part one of our two-part webinar series. I am hoping that Louise is going to be joining any second now because she is actually doing the first part of our webinar. So our learning objectives will be to understand the types of post-acute care, recognize the relationship between transition of care and hospital readmissions, become familiar with the IMPACT Act and its implications, identify some risk factors for readmission, and examine utilization, cost, and quality in post-acute care. So first we wanted to talk about what is post-acute care. I think I had hit something wrong there. Kim, did I hit something? Have I changed the screen for you? Okay, good. So this is just a slide to kind of help you understand what the post-acute care lexicon is. The acronym of IRF for inpatient rehabilitation facilities, and SNF, as we refer to it, as for skilled nursing facilities, LTAC, long-term acute care and long-term acute care hospitals, and HHA, which is our home health agencies. And we added to this slide the, as you can see, the dollar signs to kind of give you an idea of the relative cost of these particular services. So challenges in administering post-acute care services. What seem to be the top challenges in administering post-acute care services? Care coordination, as you see, is 21.2. Readmissions, which we'll talk about later in the presentation as being a real challenge for post-acute care, and some of the proactive responses you can do to help prevent your readmissions. Discharge planning, which is a huge component of care transition. Our stakeholder engagement at 9.6%. And then again, the 25% of care transitions, which seems to be a struggle throughout the country when you look at all of the HCAP scores. Care transitions nationally ranks right around 52%. So why focus on post-acute care utilization? Well, there's been a 90% increase in post-acute care utilization from 2002 to 2012. 64% of Medicare patients are readmitted after an inpatient stay received no post-acute care. That's very interesting. And 35% of Medicare patients receive post-acute care. So of course, we would want to focus on the utilization of post-acute care and the cost and quality associated with that. What is the most critical transition of care? With this particular HIN study, it was April of 2015, we see that the most critical transition of care is hospital to home. There is also a large percentage, next in line, 23.7% of post-acute care, hospital to post-acute care, pardon me, and so on. This slide shows the post-acute care discharge trends. 46.2% are discharged with home health agencies. 41.5% to a skilled nursing facility. 3.1% to a rehab facility, inpatient rehab facility, and then 7.7% to other discharge means. Why focus on post-acute care costs? Well, hospital readmission penalties and CMS and commercial bundled payment initiatives have increased the focus and concern about the cost and quality of post-acute care. The President's budget for the past 3 years had proposed to bundle 50% of post-acute care payments by 2020, and it looks like we are definitely on the way to that. with a goal to reduce the healthcare spending. Under our bundled payment model, an entity receives a single payment from a payer that covers all of the related services needed to treat a patient for a condition, or what we are commonly hearing is considered an episode of care. So as we know, the passage of the Affordable Care Act in 2010 heightened our focus on the Institute of Healthcare Improvement's triple aim: improving the patient experience of care, improving population health, and reducing per capita costs of health care. But historically, the post-acute care hasn't been on the radar screen as much as other methods of care. An Institute of Medicine report in 2013 had identified post-acute care as the source of 73% of the variation in healthcare spending, significantly increasing the attention to the post-acute care sector. And later on in the presentation, we're going to look at some variation of post-acute care as well. So it's estimated that as many as 43% of our Medicare fee-for-service beneficiaries are discharged to one of the Medicare-recognized post-acute care settings: skilled nursing facilities, long-term care facility, inpatient rehab facilities, and home health. Between 2001 to 2012, program payments to post-acute care providers doubled to $59 billion. And it's my understanding, I think that actually came from a MedPAC report to Congress in 2015. So this slide shows Medicare spending on post-acute care by sector from 2001 to 2013, with the steepest rise in the skilled nursing facility expense, and then the most modest rise in long-term acute care settings. Excuse me, let me go back. It looks like on the skilled nursing facilities that there was an increase of like 16 billion, $0.7 spent for skilled nursing, 9.46 for home health agencies, 2.76 for inpatient rehab facilities, and 3.36 for long-term care, with a total of $59 billion of Medicare increase in spending. So further analysis demonstrated a significant difference in cost related to the initial post-acute care setting following hospitalization, particularly as more hospitals and health plans move into bundled payment arrangements. You can expect to see a decrease in the inpatient rehab facility and potentially in the skilled nursing facility as well, because they will be shifting the cost set to a different setting of care for the least expensive care. Of course, in this slide, it shows that the self-care is the least expensive if someone is discharged to home with self-care, provided they have someone in the home or a caregiver to care for them. So why focus on our post-acute care quality?
Carla, it's Louise. I would just interject. Can you all hear me?
Yeah, do you need me to go back to a slide?
No, I was just going to interject or really add to, related to the average episode spending. The other point that's of interest related to these trends specifically is that the initial post-acute care setting really is a major determinant in what then the long-term, the overall total cost of care will be. One of the other things to make note about is that in many instances an individual patient will actually go from one post-acute care setting to another, which is what these this combination of bars then really further highlights, so that then cumulatively you have the total cost of their participation in one or more post-acute care settings over the course of that recovery period.
Okay, so as far as, so on September, I'm sorry, I've got really bad laryngitis. On September 18th, 2014, Congress had passed what's known as the Improving Medicare's Post-Acute Care Transformation Act, known as the IMPACT Act. This act requires the submission of standardized data by long-term care and skilled nursing facilities, as well as home health agencies and inpatient rehab. And the Act has broken down the different domains and metrics in patient assessment. Examples of those patient assessment metrics are special services that are needed, cognitive functioning and changes in cognitive functioning, quality measures related to skin integrity and changes in the skin integrity, medication reconciliation falls as part of that as well. And then resource use measures, Medicare spending per beneficiary, transfer of information, and rate of discharge to the community. The purposes of the IMPACT Act are to compare quality across the post-acute care settings. Additionally, to help inform hospital discharge planning and create a foundation for potential future post-acute care payment reform. The IMPACT Act also provides an opportunity to address the CMS quality strategy and national quality strategy to provide better care, healthy people, healthy communities, and affordable care. So this table indicates the sectors on the left of long-term care, inpatient rehab, skilled nursing, and home health. And when we will be seeing the IMPACT Act timeline take place. So the report of standardized patient assessments will take place October the 1st of 2018 for everything other than home health, and home health will begin in January of 19. In the far right, the reported resource use measures will begin for all of the long-term care, inpatient rehab facilities, and skilled nursing facilities in October of this year, and then home health in October of 2017. But the beginning of the reporting of all of the additional quality measures will begin in 2016 for specific measures, and then 2017 for home health specific measures, and 2018 for long-term care, inpatient rehab, and skilled nursing facilities, and then additional measures for home health in 2019. This was the slide I was mentioning earlier about variability. There's quite a bit of variability across the skilled nursing facility providers. And that had something to do with, obviously, the quality measures that were chosen in patients that are discharged to the community, avoidable rehospitalizations during a skilled nursing facility stay, and potentially avoidable rehospitalizations within the 30 days of the skilled nursing facility stay. Average mobility improvement across 3 mobility activities of daily living, and then no decline in mobility during a skilled nursing facility stay. Nursing home compare metrics are another method for of quality reporting. And from CMS, Nursing Home Compare allows consumers to compare information, much like HCAHPS information is compared and benchmarked. It contains quality of care and staffing information for all 15,000 plus Medicare and Medicaid participating nursing homes. Nursing Home Compare includes information on the 5-star quality ratings, on the health and fire safety inspections, and that includes a detailed and a summary about any deficiencies that were found in the last 3 years. Those comprehensive inspections are conducted annually, and the last 3 years of any complaint investigation. Nursing home staffing information about the number of registered nurses on staff at each facility, LPNs or vocational nurses, physical therapists and nursing assistants in each nursing home, as well as a set of quality measures that describe the quality of care in nursing homes, including the percentage of all residents with a pressure sore and all residents with urinary incontinence. And then there are many others found on the same site. And then any penalties that have been imposed on a particular facility. As far as readmissions, in 2013, there were about 500,000 readmissions totaled $7 billion in hospital costs for the 4 high-volume conditions that I'm sure we're probably all familiar with: AMIs, congestive heart failure, COPD, and pneumonia. These 4 specific conditions cost Medicare $5.2 billion in 2013. And from 2019 to 2013, the readmission rate for stays covered by Medicare decreased by 13%, for AMI by 7% for each of the other CHF, COPD, and 6% for pneumonia. It's thought that this decrease has occurred due to all of our real focus on readmissions for these top 4 diagnoses. Hospitals risk losing up to 1.5 of their Medicare reimbursements if they don't show improvements in their process of care measures and their patient experience. And by 2017, that could grow to 2%, which equates to millions of dollars for an average hospital. Readmissions are a significant portion of Medicare spending. 37% of total Medicare spending for inpatient care, and 18% of all inpatient admissions paid by Medicare are readmitted within 30 days. That accounts for $15 billion annually. And pneumonia is responsible for an estimated $6 billion in direct costs each year in the United States. So why do we measure readmissions? Well, it's very relevant to patients. It's useful for improvement. If we don't measure, we can't manage what we don't measure. And it's fair for accountability. For patients, poor coordinated care leaves them isolated, confused, and at risk. Medicare's current readmission metric, 30 days and 3 conditions, does not capture the patient experience. Hospitals need evidence-based measures of success to coordinate care efforts. Again, you can't manage what you can't measure. And holding hospitals financially accountable for readmissions is a step in the right direction, but the Medicare readmission penalty does come with many issues. Risk factors are considered, they're in this particular situation, the APs, risk factors for readmissions. Problems with medications. There are a large number of patients that have what is known as polypharmacy. That can be different in different hospitals, but typically it is greater than 10 or greater than 10 routine medications, or those that are on high-risk medications like anticoagulants, antiplatelet agents, insulin, oral hypoglycemic agents, digoxin, and narcotics. And what we also see throughout the country is that there are patients that are being discharged where the medication reconciliation has discontinued a medication and added a new medication or maybe a new dosage, and the patients have been gone after discharge to their drugstore and filled all their medications, so they're taking duplications of medications and not having a process to discharge those medications or discontinue the medications at the pharmacy has created a lot of problems for our patients. Psychological, where patients who are screened positive for depression or who have a history for depression is a great risk for readmission. Also, you may want to choose to include those that have anxiety and substance abuse in that screening. Patients with the principal diagnosis for hospitalization related to cancer, strokes, diabetic complications, COPD, or heart failure are at risk for readmission. Patients that have physical limitations, they're very frail or deconditioned, that creates a real issue for them to have any self-care in their activities of daily living, and potentially their medication administration as well. Patients who are unable to demonstrate the understanding of your care, of the care plan at discharge. Poor health literacy is a huge issue. Patients that don't understand but just shake their head and say they do. In order to help, if you use TeachBack as part of your process of teaching, education, and discharge processes. And those with poor social support, if they don't have reliable caregivers to help assist with their discharge process or to help transport them and such. It's also many hospitals we see have shared that they have had frequent readmissions from patients that have no one at home. And so their hospital environment is like a social environment to them, and they feel better cared for. Also, a risk factor for readmission is prior hospitalization. Unplanned hospitalization in a 6-month period prior to that hospitalization, it should be noted. There should be a readmission risk assessment done that would help you to identify that. And then also palliative care. When you think about a palliative care patient, you need to think about whether or not that you would be surprised if that person would be passing. I saw another question that was posed to physicians when they needed to have crucial conversations with patients. And the question was asked, would you be surprised if you saw this patient's obituary? If not, then that crucial conversation needs to happen with the family about if the patient is going to be staying at home instead of being readmitted to the facility for their palliative care services. This is the readmission financial penalties that have been seen from starting in 2013 for different conditions, and how that impacts the readmission at the penalty at the readmission base rate of $6,212. You see that the proposed amount for stroke and for a coronary artery bypass graft is extremely huge. What that's predicted for 2017. So the current studies show that 7% of acute care hospitals currently have higher than expected readmission rates. Some of the avoidable readmissions may occur because of an adverse event that happened during their initial hospitalization, or as an appropriate, a result of an inappropriate or lack of follow-up care following discharges. So potentially appointments not met or kept, transportation issues in small rural areas. There is very unlikely to have any public transportation. Those patients that are also in wheelchairs, public transportation is very difficult to find. And not having their medications, whether they can afford them or not picking them up, is a potential issue. And some hospitals are initiating a new, what they're calling meds to beds, to make sure that the patients have their medications at discharge before they leave the hospital. And avoidable hospital readmissions are often considered indicators of poor care or missed opportunities for coordination of better care. Readmissions for some of our top conditions, again, heart failure, 87.5% were readmitted once after a heart failure hospitalization, 9.7 readmitted twice, and 2.8 readmitted 3 or more times. Again, after AMIs, 97.4% were readmitted once, 2.4% readmitted twice, and 0.2 were readmitted 3 or more times. With pneumonia, 95.1% were readmitted once, 4.3% were readmitted twice, and 0.6% were readmitted 3 or more times. Clearly, these discharge diagnoses should be a target for improvement at all of our facilities. There's also a real potential negative impact of readmission. The decreased margin is very, very costly. Hospitals are denied payments for readmission. PPS hospitals pay a penalty if readmission rates are above the accepted rate, which was 3% for 2015 and beyond. There is an increased cost to manage care, which is an issue with DRG payments, bundled payments, and capitated models, or ACO payment mechanisms. Readmissions can be very disruptive to our patients and families, affecting patient engagement and HCAHPS outcomes. There are more chances of increased mortality with readmissions. It not only affects the family, but also impacts the revenue under hospital value-based purchasing due to the penalties. It's also publicly reported. Decreased utilization and poor image. Your community doesn't want to come to your facility when you have terrible readmission rates. It's also a very not desirable partner for affiliation. So if your facility was considering looking for a partner for affiliation, someone another facility would not want to be affiliated with you if you have a higher readmission rate. So as we look at a proactive approach, one great resource is known as Interact. The next two slides show results from a study that was completed to analyze the root cause analysis of transfers from skilled care to acute care hospitals. The top part of this slide shows the actions that were taken to evaluate and manage the changing condition. The second one, it's interesting that the length of stay prior to the hospital transfer had been at the highest anywhere from 7 to 29 days or 90 days and more. The next two blocks show opportunities for improvement. Is the transfer related as preventable? 23% said out of 1,044 patients that 20% could have been rated as preventable for transfer. And then at the bottom, opportunities for improvement. Look as though changes could have been detected earlier, which is high, and out of 372, 36% of those may have been able to be managed at the nursing home had they had the available resources. The Interact website includes resources on care transitions, fall management, advanced care planning, managing behavioral symptoms, and numerous resources on quality of care. Louise, are you still there?
I am here, yes.
Okay, you're up with that.
All right, and I just want to add in terms of Interact, it's actually that Interact program was developed by a geriatrician and his team, and it really is, it has been embraced nationally as an important quality of care initiative or program